So today I've got the task of talking about neurosurgical procedures, which is not an in-service that I would say is going to kind of change clinical practice as such. It's more just a review or refresher, depending on how much experience you've got, of the different neurosurgical procedures that clients we see might have been through. My kind of background back home is that I'd done a fair bit of work in neurosurgery there. So I'm really just kind of have put stuff together to go through what I know about it, and if anyone, I know you've worked in neurosurgery as well, Anna, so please do chip in, or I don't know if things are done differently here, or to what extent procedures are the same, different, there might be some slightly different terminology used, so do just chip in and we can make it interactive. So what I'm going to do today is just talk about the common neurosurgical procedures that clients might have had, outline kind of the acute onset of them, and then how they might be managed surgically. And also just talk through some of the complications of surgery, or it might be that we're seeing clients post-op further down the line, and we might be the first person they're reporting symptoms to that might need investigation, or might not even be post-op surgery, but they might be reporting symptoms where you just think that doesn't sound quite typical of the condition that you're seeing, and there's actually something else going on as well. So I've broken it up into talking about common spinal surgical procedures and then brain procedures as well. So the first one is an anterior cervical discectomy with fusion. Does it get called ACDF here? Yeah, good. So this would classically be performed for a myelopathy or radiculopathy. So myelopathy being a pathology of the spinal cord, and radiculopathy at the problem being at the nerve root itself. So patients might present with a really heavy feeling in their legs before having this procedure, might not be able to walk at a faster pace, have a deterioration in their fine motor skills, so handwriting, using a comb, doing up buttons, and have electric shock-like pains, particularly in their arms and legs. And if it's a radiculopathy, then arm pain as well. So those are the things they might have gone to the GP about prior to their surgery. Likewise, it might be symptoms they're reporting to us. So the idea is that the source of the anterior cord compression is removed through a discectomy. And with the anterior cervical discectomy, they go in through the front of the neck. I've got a picture here. Don't know how that's... Yes, you can see the dotted lines at the top there. The incision's actually made at the front, and then the muscles are retracted to expose the vertebrae, which is deemed to be less painful than going in posteriorly and actually cutting through the muscles and the soft tissues. So there's less of the muscle stripping from the spine. So the discectomy is performed, which is essentially a decompression, and then usually, either a bone graft or an implant is placed in between the vertebrae, which the unit that I worked on, they would use an implant, but my understanding was that it's surgical preference as to whether it's a bone graft or a kind of a C-space or a cage. I don't know if it's the same here. More, sorry, did you say more bone grafts? Yeah. And again, the clients that we used to see, or patients back home, they would usually be told that it wasn't necessarily going to improve their symptoms, but with this, particularly if it's a myelopathy, that it's to prevent further deterioration of symptoms. I don't know if that's more to do with the huge waiting lists back home to have it done. Maybe if it's done a bit more acutely, then the symptoms wouldn't be so progressed before they have their surgery. And then with the ACDFs, they'll have stabilisation by way of fusion at the same time. So another one that's we might commonly see is a laminectomy, so usually cervical or lumbar. So the lamina, picture, is the part at the back, and they will go in, if I come here, so it covers your spinal canal. This will typically be done for either canal stenosis, cauda equina, or a central disc protrusion. And they're trying to decompress either the nerve root or the spinal cord through making the canal larger. So at the same time, there might be thickened ligaments. They'll remove that. and then they can remove bony spurs through there. Hang on, I've got this picture here so you can actually see it. Sorry, it's a bit small up on the screen here, but it shows where they make like the little window in the lamina, and then they can access the cord through there. So again, there can be complications with this if there's a tear of the dura. So clients might be on bed rest post-op for a couple of days, which isn't, by the time they reached us here, it wouldn't be as relevant, but acutely, you would have a different approach with them. You might be looking more at bed exercises or something before they can get up and mobilise. And again, a laminectomy might be performed if someone has a spinal tumour, which could be either an intradural tumour or extradural tumour. And depending on if the dura is opened or not, then there'd be a different post-op protocol, which again, by the time we see clients, they should be kind of full mobility and not have the restrictions, depending on the extent of their neurological deficits. More often we'll hear about is discectomies and microdiscectomies, which are for lateral disc protrusions. So usually if clients had unremitting leg pain or recurrent attacks of it and it's not responding to conservative management, or they might be developing neurological deficits, so then they would go in for more of an emergency surgery. When I first started working on neurosurgery and heard about microdiscectomies, I just thought it meant like a really small discectomy, as in like micro, before I realised that actually it's because they use a microscope, so the incision is much smaller, so it gives the surgeon a better view. And these pictures here will show the difference. I don't know if you can see at the top there's kind of the black dotted lines. So for an open discectomy, a standard one, the incision will be much bigger. As opposed to kind of just a smaller stab wound when they go in and sort of gain the access through a retractor, and then the microscope gives a much clearer view for the surgeon, and then they can remove the herniated disc material to relieve the compression that there is. So that's kind of the main ones for spinal surgery. You can also have, they might do a correction of a scoliosis, spondylolistheses, touch briefly on removal of spinal tumours, and also stabilisation for following spinal trauma. But similar procedures with the fusions and the discectomies or laminectomies for them. So next up is brain surgery, where you'll hear the term cranie, so be it craniotomy or craniectomy. If you think of sort of a craniotomy is essentially a trapdoor, so that's how they'll access the brain. So the bone flap is removed, they'll do their surgery, and then the bone flap is put back in. So the trapdoor's removed, the trapdoor's put back in. In some cases it will be a craniectomy where it's removed and it's not replaced. That is either for decompression of the brain, or it might be because of the bone quality or infection in the bone, so they won't replace it, and people will, some people, again I don't know what's common practice here, but wear a skull cap or a helmet, and then they may further down the line go back in to have a titanium plate inserted. They can sometimes store the bone flap in the pelvis, can't they? And then we had an instance where it was like they'd lost the bone flap. We're like, how? Where is it? So different types of brain surgery that might be, or reasons for it. So subdural hematomas, these can be acute or chronic. And typically are more of a kind of a crescent shape, as you can see here. So a little bit more crescent, kind of concave in shape. They can be acute or chronic, but the chronic ones tend to be in the older population, so clients with more cerebral atrophy, or those that are on anticoagulants, so just a really minor head trauma could cause a bleed. But where the older population will have cerebral atrophy, there's more space already in their brain, so they tend to accommodate the bleeding or the increased pressure more so. So their history will be really gradual. It might be they've just had more falls than usual, they've become incontinent, they've been more confused, but it can generally be sort of a little bit of a vague history, and then it just exacerbates as the pressure builds up. Approximately 50% of the chronic subdurals will have no associated head trauma, but there may be kind of a minor head trauma. I've heard of people that just sort of bang their head against a cupboard door or something when they open the cupboard door, and then sort of weeks down the line they're presenting with more falls, and they have a chronic subdural. So the chronic one being more of the darker colour as opposed to the acute blood on the top one. And the acute presentation has a higher mortality rate than the chronic, because it's often associated with more cerebral contusions as well. So again, we might have clients where they have this kind of vague onset, but symptoms are getting worse over time as opposed to better, maybe if they're attending for falls and balance. So essentially what happens with any of the subdurals, there's bridging veins that go across the subdural space. So as there's cerebral atrophy, these veins are already having to travel a longer distance anyway, so they're weakened and they're more prone to shearing forces. So if there's any kind of trauma and there's a tear in those bridging veins, then that's where the bleed is and where the blood will collect. So these are usually evacuated via burr holes or sometimes a mini craniotomy. No picture. And so there'll be the sort of drill through the skull, and essentially it's like an irrigation or suction where they'll wash out any clotting that's there, any of the old blood. And then a small rubber drain's put into the space to drain away any fluid that might collect, but that's usually removed after a day or two. So less often a craniotomy would be performed, but that's obviously a much larger operation. So next up, if you've heard of the extradural hematomas, so these are usually traumatic and, generally more serious. These people might present following head trauma. They might have lost consciousness at the time of the trauma, but then actually made quite a good recovery, be quite lucid for a few hours. And then as the blood collects, that's when they then become really unwell again. Which is why if you've ever had a head injury or head trauma at all, they'll always say, someone going to be with you overnight, or making sure that you're not on your own, that you're being monitored initially. So these are more convex in relation. So you can see here, they go more out. So that's essentially they're going to put more pressure on the brain as they grow because they're going inwards like that. And the picture at the top just shows the difference. You've got subdural on this side and an extradural one on that side. So the red line being the dura, and you can just see the sort of slight difference there in them. And this, if they're, these pictures haven't got them, but if it's a really large extradural hematoma, then it will cause midline shift. So there's just essentially not enough space on that side of the brain for the blood, so it just sort of shunts everything over. And these will be treated with a craniotomy to evacuate the blood. And again, this is quite often where they may then have a craniectomy, so the skull's not removed, just to allow space for the swelling and to decompress the brain. So the next one I've got here is subarachnoid hemorrhage. So this is bleeding into the subarachnoid space. So that's the thin lining that covers the brain. You can see just up at the top there. And the presentation for these, as I'm sure I've certainly got clients here that have post-subarachnoid hemorrhage. And they'll present with the worst headache ever, sort of a thunderclap, 10 out of 10 headache, neck stiffness, potentially loss of consciousness, and light sensitivity, double vision, potentially seizures, sort of a combination of them. But the primary one is that worst ever headache. accounts for approximately 1 in 20 sort of straight classifications. Sorry, it's an English statistic. I looked for an Australian equivalent, but I couldn't find one, but I figured it would be fairly similar. And most commonly, these are because of an aneurysm bursting, but you might also have it as a result of a bleed from an AVM or a traumatic subarachnoid hemorrhage. So an aneurysm being a bulge in the blood vessel, and an AVM is more of a tangle of blood vessels, and there's a much higher rate of bleeding in them than a normal blood vessel. So that is just, I'm quite a visual learner, so there's lots of pictures in here, but you can probably look at them a bit closer actually on a close-up screen. So the management for the subarachnoid hemorrhage is acutely. They'll have a CT scan and an angiogram, and then they're managed either through coiling or clipping. There's a high risk of vasospasm in the acute stages, which is narrowing of the arteries in the brain, so a spasm of those arteries. So initially, and this is just from the neurosurgical unit I worked in, and I think even within England the management of them are slightly different, that people might be on bed rest in the first couple of weeks where they've got that really high risk of vasospasm. I don't know if you know of that here.
Well, we didn't do clippings and coilates where I worked in neurosurgery here, but in the UK, yes, they would potentially be on bed rest.
Yeah. Yeah, good. So nimodipine is a medication which is essentially going to relax the narrow blood vessels, so you're increasing the blood flow to that area of the brain, so you're getting more perfusion, more blood flow to essentially reduce the brain damage that there is. There's also, because of the risk of vasospasm, something known as Triple H therapy. So it's hypertension, hemodilution and hypovolemia. So you're keeping the blood pressure up to help perfusion, you're keeping the blood volume high, and you're keeping the plasma within the blood high as well. So, like I said, they might be on a bed rest procedure initially. I think, yeah, some variation depending on the grade of subarachnoid hemorrhage that there is. So one form of management is the craniotomy and clipping. So they will go in, the neurosurgeon places a tiny clip across the neck of the aneurysm. Yes, here at the bottom one, so I'll just put a little clip where you've got that bulge. And that just blocks the normal blood flow through the vessel from actually entering the aneurysm and being at risk of a rebleed. And the clips are made of titanium and they will stay in permanently. And then in the 90s, coiling was introduced more. So it's an endovascular procedure where they will place coils into the aneurysm, as you can see at the top there. So they'll go up through a catheter from the groin. I still don't understand how they do it. It's incredible. But essentially they're placing coils into the aneurysm. Several coils might be used, so a post-op note would say 6 coils used, and it would indicate the size of the aneurysm that somebody had. And again, they remain in the aneurysm. They're not removed, but they will prevent blood from flowing into it and having another rebleed. So the blood then clots around the coils and kind of seals it off as an entrance for the blood. So my understanding is the coilings are less invasive nature, so for anybody that is more elderly or has a complex past medical history or any serious medical conditions, that they would choose that option. That for younger patients, the safety between coiling and clipping is really minor, and that the longer term protection might be from the clipping in terms of life expectancy. But I don't know if that's just because coiling's a new procedure, so the long-term follow-up on it's less. But yeah, I think also depending on where the aneurysm is, so if it's a high-risk area, they wouldn't necessarily want to open up and go in through a craniotomy and clipping. This picture I thought was just quite a good one for a general overview of all the different terminology that you have in terms of the intracerebral hemorrhages, intraventricular, extradural, subdural, subarachnoid. So it just shows the different areas where you can have the bleeds in the brain. Yeah. So in terms of, so if there is a bleed on one side or a tumour or, yeah?
Like, is it something space occupying?
Yeah, so kind of think of it a little bit, if you think of your skull as a box, and then within that box you've got brain tissue, you've got fluid, and you've got blood, and there's essentially not space for there to be too much of one of those things, apart from brains. And so if you were to have a bleed or a tumour or anything that's occupying that space on one side, I have got a picture in a follow-up slide actually of the midline shift, but the bit down the middle here just kind of shunts across, so you see that it's not equal left and right. And then that's where clients will present with more confusion, drop in GCS, any of your other neurological signs. But is that the kind of thing you meant? Or
yeah, I suppose also, like, if you think about what happens when you're shifting the brain across, if there's enough of a shift through that midline point, there's enough pressure over onto the other side, you've got the potential scope, if there's enough of it, to then get symptoms resulting from that side being compressed to the brain. So you could have somebody potentially presenting with bilateral symptoms, which would probably usually only be the case in quite a severe situation. Yeah. But also, if you've got enough of a midline shift or enough compression from one side to even onto the ventricles, you can have a reduction in the flow of the CSF through the ventricles, and the sort of the most likely complication of that being the risk of developing hydrocephalus. So you guys aware of hydrocephalus? I've
got some slides on that. That's where I've gone into the midline shift a bit, but no, not in as much detail as that though, so that's good. Is there anything else you wanted to say?
Well, I mean, one of the things that we used to really commonly both in the UK and in neurosurgery here was the treatment of hydrocephalus and putting in shunts. So either just putting in a drain and draining the hydrocephalus, or putting in an internalised shunt that would then most commonly drain into like the abdominal space, and that's just then can stay in as a permanent cleaning exercise to make sure you're not getting that build-up of fluid.
I've got some pictures of that.
Visual learner. Or we might have an extra ventricular drain, which again, by the time we see them here, that's not going to be an issue, but in the acute setting, that's just externally draining.
So another, in terms of kind of talking about space-occupying lesions, so things taking up space in the brain, one of the first ones I've got here is an acoustic neuroma, often referred to as a vestibular schwannoma, and it's a slow-growing tumour, but it is benign on the 8th cranial nerve, so it's in the cerebellopontine angle. These clients will present with tinnitus, dizziness, poor balance. They might have facial symptoms of pain or numbness or pins and needles. They can develop deafness as a result, and even nystagmus or ataxia. More often in middle-aged women, unfortunately. And so post-operatively, and again this is more acutely, but it might be a reason they're referred for follow-up physio, would be a facial assessment and a balance assessment, probably the key things. And then they might be treated with stereotactic radiotherapy, so really targeted radiotherapy. Unless what? Yeah. She's probably diagnosed them. I remember when I was doing this, it reminded me of a case of somebody I saw in outpatients back home, who, it was really sad actually, he must have been about, I think he was probably early 50s, and he had a known acoustic neuroma, so he was about 80% deaf in one ear, I think he was on the waiting list for surgery, or he was being monitored or something by the neurosurgeons as to whether they were going to operate or not because of it. He then, when he was at work, he had a drop attack, so he had an undiagnosed cardiac condition, gave himself a head injury from hitting the floor. His head injury then made him, I think it was 100% deaf in the other ear, and so he just had no hearing. His balance was not good, his confidence to go out, and it was just one of those cases that just struck I don't know, the whole assessment with him was written. He couldn't read and, you couldn't communicate verbally because he couldn't hear all the questions you were asking him. And then when it got to questions about, what are your hobbies, what are your lifestyle things, and he said, I've always loved listening to music. Couldn't do that. He'd lost his sense of taste. So he said, I'm losing weight because I'm only eating like for substance rather than for any enjoyment from food. It's so sad. But he was an amazing patient, but it was like every question I asked, I can put a positive spin on this, and everything, it was like, oh no. And then he said he had a really good sense of humour still, and he kind of hadn't talked about his family for a little, just in the initial assessment. But then he said, oh no, my mother's down the road, but she's really deaf. We can't talk to each other. We just end up, she's shouting at me and I'm going, I can't hear you. So we do come across them in outpatients. And like you said, Vanessa will definitely have done here. So there's some pictures here to kind of show where the tumour might be. Both on the scans there, and more of the animated picture. And then the different areas where they might go in surgically to remove the tumour. So further discussion then in terms of removal of space-occupying lesions. So predominantly tumours this would be, which they'll refer to as a debulking, so it will be done through a craniotomy. And the idea is to try and remove as much of the tumour as possible without damaging the surrounding brain tissue. So this is much easier for benign tumours than for malignant ones, which tend to kind of infiltrate the surrounding brain tissue, which you can see here. So the top picture, you've got a low-grade tumour versus a high-grade. The high-grades might be associated with more bleeding as well around the tumour. A grade 3, so that's sort of a higher grade tumour would be classified as. In the bottom picture here is a meningioma, so they are generally, they're benign tumours, usually easier to extract. And then this picture here does show some midline shift across. You can see there's a really large high-grade tumour at the top, and it's kind of shunting things over a little bit. History with brain tumours is always can be a really vague history. Quite often, people will have been going back and forth to the doctor with symptoms, but it can just be things like they're feeling more drowsy, they're having headaches, which if a doctor kind of diagnosed a brain tumour every time someone said they had a headache or they were feeling tired, it would probably be slightly overdiagnosed. But yeah, you can also, sometimes it's instantly there's neurological deficits, weakness, sensory changes, speech problems, seizures. But they can be more subtle. Memory problems, personality changes, headaches, drowsiness. And there's pituitary tumours as well. So these ones are removed via transphenoidal approach. There was a picture somewhere. Here. So they'll actually go in through the nose to remove the tumour. So then you see people with it all kind of packed up post-op. But it does every time. I know. And I think these clients as well, there's risks of kind of CSF leaks. So it will be, I don't know that we would necessarily be seeing someone here after it. They generally don't need physiotherapy involvement, but if someone's saying they're just getting a dripping from their nose, so particularly if they lean their head forward and like fluid's just dripping out, it's a little bit like when you've got sinus infection or something, then it's just important to make sure doctors are aware of that. I'm kind of more familiar with that really acutely, where you would just tell the neurosurgeon that's on, but I don't know that we would necessarily come across these clients, but it's just quite interesting. So then hydrocephalus. So Anna, I might get you to jump in here. There's different types of hydrocephalus, which is where it can get a little bit more confusing. But essentially hydrocephalus is where there's excessive accumulation of CSF within the brain. So the normal flow of CSF is that it will go through the 4 ventricles down through a small opening at the base of the brain, and then it covers the surface of the spinal cord and the brain. So, and then it's reabsorbed back into the bloodstream. So it's just flowing through the body like that. And essentially it's to deliver nutrients, protect the kind of the spinal cord and the brain, and to remove waste. So if there's so there might be a blockage to this flow of CSF, which is when hydrocephalus can develop. And that can be a communicating or a non-communicating hydrocephalus, which is where it gets a little bit more technical. Or it could just be the body's inability to absorb the CSF. So CSF's building up within the ventricles and the subarachnoid space, so that causes swelling or enlarged ventricles, which then puts pressure on the brain and can stretch the nerve fibres. So these patients might present with cognitive dysfunction, visual disturbance, poor mobility, incontinence, spasticity, altered consciousness. But it can be congenital, so you have babies that are born with it, either because of problems of fetal development or a genetic disorder. And then the other side is an acquired hydrocephalus, so because of a tumour or a bleed or an infection, and essentially it's just blocking that circulation, the circulation channels. So this is one example. So the ventricles are enlarged because of the CSF build-up. And then this picture, which I don't know if you can see it that clearly from where you are, but it just showed it from a different angle, and it kind of shows where the different ventricles are and how the flow would normally go of the CSF. And then on this side, you've got an obstruction, which is enlarging the ventricles. So the communicating hydrocephalus, you think of it that there is full communication between the ventricles and the subarachnoid space. So the block is after the CSF's exited the ventricles, so it can still flow between the ventricles. Whereas non-communicating, which I think interchangeably gets called obstructive hydrocephalus, the flow is blocked between one or more of the channels, the pathways between the ventricles, so the ventricles are not communicating with the subarachnoid space. And then there's normal pressure hydrocephalus, which is often following kind of a TBI or stroke or having a tumour, where the CSF builds up within the ventricles, and then they enlarge and put pressure on the brain. I can't claim to be any kind of specialist on hydrocephalus. I did find it a little bit confusing when I really tried to go into the different types of it. But it's really kind of depending on where the blockage within the circulation system is. But essentially the ventricles are larger, which is putting more pressure on the brain. I have got some other pictures here as well. So this one is communicating hydrocephalus. So an example is with meningitis. So the third and fourth ventricles there are enlarged. Whereas the one on this side is a non-communicating hydrocephalus. So this one, they've got the third ventricle is large, but the fourth ventricle is small. But that's the neurosurgeon's job to decide what type of hydrocephalus it is. And then this one here, so this one, because of a tumour, which you can just see in the top of the bit that's marked C. So this is a bilateral obstructive hydrocephalus, and then the second picture is post-op once the tumour's removed, so you can see the ventricles are much smaller again. And then this one is more of a generalised ventricular enlargement, so communicating hydrocephalus. This case said it was a 69-year-old with ataxia, dementia and incontinence. I don't know, do you have anything else to add about hydrocephalus? I've got some bits about shunts next. I don't know. So there's the lady that most of you have met now that has had a subarachnoid hemorrhage, and she's recently had a shunt inserted because it turned out she had hydrocephalus when she went for a kind of a review scan. I don't know what type of hydrocephalus she had, but I would imagine there's residual blood and that were causing. sounds likely. So then this is just a little bit about shunts. So some of this is more acutely than now, but kind of the first stage might be a lumbar drain. So it's similar to a lumbar puncture. There's a thin catheters going into the subarachnoid space between two vertebrae to collect the CSF. So it might be done more for diagnostic or therapeutic reasons, but would only really be for a few days. And it can just monitor and drain, so it might be reading the pressures as well. Have a picture there. So the lumbar drain on this side, so there's just a small thin catheter coming out. The next one might be a lumbar peritoneal shunt. So this is channeling the CSF from the lumbar area into the peritoneal cavity. So this picture in the middle. So this might be done if the ventricles are too small to place the shunt into. So it's often for hydrocephalus or benign intracranial hypertension, where people will classically have smaller ventricles. So the fine catheter is inserted and fed up the spine, and then rerouted, and another incision is made in the abdomen to drain the fluid. And then a VP shunt, so a ventricular peritoneal shunt. This will direct the CSF away from the ventricles, so it goes sort of down behind the ear. You can feel it in people's necks. So this is what I think this lady's had. I haven't actually seen her since, but and then it goes down the side of the neck and then into the peritoneal cavity. So this will be if there's too much CSF in the brain and the spinal cord within the ventricles. But if it can lead to a build-up of fluid that needs to be diverted away. So if there's a blockage, as we said, within that circulation system. The problem is that shunts do block. So quite often people will be going in for revisions. Maybe it was just the nature of the different people that would come in for us. Maybe I think we had some people that were just currently coming back in, but it doesn't mean that everybody that has them will be coming back in for revisions. But I did see a statistic that said that they generally do block over 5 to 10 years. And there's just the picture of the VP shunt, so running down behind the ear all the way down into the abdomen. So I think that's all that I have there. Yes, that's it. I don't know if there's any other questions or things that people want to add. How do I turn this off?
Most of these people come to us, there's not going to be particularly any contraindications or significant precautions even. It's more just an understanding of what's going on for them. It's background knowledge, really.
I think that's it. This isn't something that will change anything that you're doing with clients, but I think it's sometimes quite useful, depending on what experience you've had, I didn't know the majority of these terms before I'd worked in neurosurgery, kind of the real meaning of what it was that people had had. So how do I stop this? But yeah, just helpful to know, and maybe it's just some of the classic presentations where I've worked with people. I don't know the health system's slightly different here, but I certainly work with people back home where you're writing back to the GP to say they're presenting with this, this and this, and they might then go off to have the scan or a neurology or neurosurgical follow-up. But
I guess maybe of those things that we've been talking about, that's the most likely thing that you might see as a new presentation or a recurrence would be like subdurals, especially in that old, elderly, falling balance population.
And even some of the kind of more the spinal pathologies that, I don't know, if it's just some of the history with it, with the unsteadiness, the loss of fine motor skills or something, or like unremitting pain. I've got a couple of spinal patients, as in more kind of musculoskeletal ortho type presentations, but with the pain that they're presenting with, or some of potential neurological deficits that they've got. But most of them have been through doctors already.
surgeon, unfortunately, put together.
So I don't really expect much change in back pain.
And if somebody has emergency surgery for, like back surgery for like bladder bowel symptoms or very significant neuropathic leg pain and weakness, and somebody has emergency